Good afternoon, members. I'm Molly Mantle, your president, and I'm delighted to welcome Dame Sally Davies to speak to us today. Dame Sally is the first female Master of Trinity College, Cambridge. She served as Chief Medical Officer for England, and before that, she was Chief Scientific Advisor at the Department of Health. In 2019, she was appointed as the UK Special Envoy on Antimicrobial Resistance, where she represents the UK internationally. Dame Sally, welcome.
Thank you very much, Molly, and good evening, everyone, all members. So I'm going to talk particularly about antimicrobial resistance because I am the UK Special Envoy and you've got your own Trinity College, I know it well. The Prime Minister appointed me to this role to work with international partners across the world to tackle one of the most existential and least known threats of antimicrobial resistance, AMR. And I have to say, it's back a Prime Minister, but these things endure unless someone takes a specific action. I've actually been advocating for action on AMR for almost a decade, starting as Chief Medical Officer back in 2013. I was CMO from 2011 to 2019. In my career, as CMO, I led our response to Ebola in West Africa. I oversaw the Novichok tragedy. I introduced the sugar levy to tackle obesity. But actually, it is AMR that remains my and the world's biggest challenge. So what I want to talk to is a bit about AMR itself, but actually how I've used my voice to break stereotypes, ceilings, and silence. You know, I am a woman holding positions for the first time. I'm a leader and a champion for global public health. And you who are students, you will be leaders, and I want you to champion global public health. The key thread underlying all of my work has been credibility and my values allied to delivery. And when people say, how do I do this or that, I say, make sure you have a reputation for delivering on your word and underpin it with values. I've used evidence to build consensus and trust. Trust is terribly important when you're working in the policy field, whether as CMO, me, with ministers between us, or representing Britain with other countries. Trust matters, as does consensus, knowing when to take what you've been offered and to move on. And ultimately, we need all of this so we have good national and global policies. I started actually as a hematologist. I looked after patients with sickle cell disease, but then I built on that career outwards and upwards, focusing particularly on the importance of research and evidence. In fact, I've made evidence my unique selling point, my USP within the civil service. I was the first UK doctor to specialize in sickle cell disease, and I built a clinical service in Brent, northwest London, that became a model for the UK and Europe. I broke new ground in multidisciplinary, multi-professional, community-facing, and patient-based, patient-focused services and research. But then I was asked to go and do some work in R&D in the civil service and eventually transitioned in as CMO to becoming a formal civil servant rather than non-secondment as a permanent secretary. First, I was responsible for the development and implementation of a regional strategy for R&D, research and development, in the NHS. And actually, what I brought to that was not only frontline, but common sense and the ability to look at issues and think, would it work for me as a researcher? Would it work for my husband as a researcher? Would it work for other friends? Because if it wouldn't, then it wasn't right. I used those knowledge or that knowledge to improve how our health ministry used science as well, re-energizing and modernizing research for patient benefit, better outcomes. And actually, I conceived and founded, having got ministerial support, the National Institute of Health Research in 2006, NIHR. And I was giving a talk recently about how I thought it up and worked with colleagues to make this happen. And in the questions, they said, you mean the NIHR? it was your creation. It was my baby. Because I wanted to create an infrastructure and a culture that really made research thrive in the clinical environment. And I also wanted to empower women researchers. I linked funding through this to the Athena Swan Charter. And people couldn't be shortlisted initially in 2012 when I brought this in, couldn't be shortlisted for very big grants if they didn't have a silver award of the Athena Swan Charter. It works to make sure that gender equality efforts are in place across higher education and research and actually beginning to work. This was really a new departure and a lot of people found it very difficult, but I do believe we get better research if we have diversity, and that starts with gender and then moves on to other types of diversity. And we need to support more people having opportunities. So I put in a lot of effort on that. In 2010, I was made the Chief Medical Officer, the 16th in 165 years, actually, but the first woman to hold the role. And I always felt in my career that to get the roles I was given of influence, I never had power, I had influence, I always thought. I had to be better than the men. I hope that's changing for your generation. And I stepped back from medical practice into public policy. That was difficult at first. I enjoyed medicine. But it was my job to persuade scientists and policymakers right across the government to consider public health objectives and build sustainable action. I was labelled the nation's nanny, which of course is gendered. It was because I was setting frameworks and guidelines for behaviours. And you have to be strict about some of this in order to help people and to be kind. I did have a spat with Nick Robinson on exactly this on the Today programme, which caused much amusement to many people. And I think the view is that I won the spat because I accused him of being sexist. My male predecessors and my successor have each, well, all of them had challenges with public perception. I had to change the status quo, both for micro and structural inequalities. As CMO, it was a great job. I had, as a part of my statutory duty, to produce an annual report on the state of the nation's health. And I decided not to do what my predecessor had done, which was a monograph on a subject. Fine to choose a subject as CMO, but if you really knew about it, because he'd done it from a public health perspective, you could find fault. And I decided on a subject, I'd bring in the experts, get them to write chapters, and then with a young doctor who would help edit it, we would write, what does it mean for policy? And that was how I did my annual reports. My first was on infectious diseases, because I actually thought this was totally non-contentious, going from community to through primary care to hospitals to very specialist. And then as people came back with their chapters, I realized that antimicrobial resistance, superbugs, which had been there when I was doing clinical practice, had grown to be a very big problem. And the solutions weren't there because the drug cabinet was empty of new drugs because we don't pay enough, we have market failure. So I felt I had to give voice to it. I listened, I learned, I acted. And actually, during my career, I've always used my platforms to tell the truth, speak to truth, and speak truth to power. Not always that easy. And I've done it whether it was ugly. I can still remember going in to see the Secretary of State and shooing everyone out and saying to him, okay, you better sit down. I'll sit down too, because what I'm going to say could well be career limiting for me, but you have to know it. And at the end, he said, ouch, I didn't like that. I don't like it, but I respect you for saying it. And I've always delivered on my word and delivered on what I said I'd do. And that serves me really well now, both in the UK and abroad, as I continue to tell it as I see it on AMR. Because, you know, it may be clear to everyone that COVID-19 isn't the last pandemic our world's going to face, and we're not through it yet. But it isn't the only pandemic raging at the moment. We've got this quiet tsunami, this quiet pandemic building up of AMR. If we don't have effective antibiotics, our health, our food systems, our environment, and our economies are going to grind to a halt. We need antibiotics to treat infectious diseases that won't resolve spontaneously. Things like pneumonia, tuberculosis, HIV, malaria. Actually, without antibiotics, we lose modern medicine. We use antibiotics to prevent infections when you have a new hip or a cesarean section. You can't have a transplant if you haven't got effective antibiotics. More than 1 in 4 patients with cancer get infections. Their lives are saved by the antibiotics. I could go on, but I promise you, without effective antibiotics, we don't have modern medicine. We'd go back to that pre-antibiotic apocalypse. But antibiotics are a finite resource. And, you know, every time an antibiotic goes into a person, an animal, or an environment even, we create conditions where bacteria become resistant to our treatment. And we've all seen with COVID-19 how bacteria are hardwired to mutate in order to survive. And I have to tell you that for antibiotics, this is compounded by our excessive use of antibiotics, both in humans and animals, and actually plants and fish farming, you name it. To meet the demands of our intensive disease-prone farming systems, we pump animal feed and water with antibiotics for preventive use. Fish farming, not salmon and trout in Norway and Scotland, but fish farming, they just tip antibiotics into the water along with the feed. It's filthy, it's horrible. And we don't break antibiotics down very well, so they go into the water systems and table and the oceans. It's awful. This cheaper alternative to good animal husbandry, you know, making sure they don't get infections because you're giving them antibiotics rather than keeping them clean, is driving resistance in a big way. And it's going to leave us defenseless medically. And actually, it's destroying biodiversity alongside compromising animal welfare and food security. This is very serious. And the scientific evidence is mounting that antibiotics and their residue are polluting our waterways in a big way. The world's largest study of antibiotics in water found that over 2/3 of more than 700 samples from around the globe contained antibiotics. And what's more, marine plastics might well be spreading drug-resistant microbes through our seas and oceans by making biofilms of AMR bugs. And that's going to exacerbate the biodiversity loss and spread AMR. Our behaviors, I'm arguing, are mortgaging the health of our planet. Your future, the future of your children. For many, it's already too late. They've died. And I've been saying this since 2011. But I had a dream about 6-7 years ago that what we really needed was good data, and that the best people to do it would be the Institute of Health Metrics and Evaluation in Seattle, who published the Global Burden of Disease. And if you haven't seen it, go onto the web and play with Global Burden of Disease, GBD. Took me a year or two to persuade Chris Murray, the boss, that he wanted to do AMR. Took me another year to persuade the Department of Health, the Gates Foundation, and Wellcome Trust to fund it. 5 years to do the work, in part led out of Oxford, the GRAM study. And just 2 weeks ago, the first and most comprehensive estimates of global burden of AMR were published by this group from Oxford and the University of Washington. They've looked at 204 countries and 471 million individual health records. And the data is truly harrowing. Over 1.2 million deaths were directly caused by antibiotic resistance in 2019. It'll be higher now. To put that in perspective, HIV causes 860,000 deaths in the same year. AMR is the leading cause of death, and tragically 1 in 5 of these deaths are among children aged under 5 years. And nearly 5 million people die with AMR infections on board as they die. So it's contributing to deaths in many more. This data is shocking. It shows the inequality and health disparities are really crippling. And globally, sub-Saharan Africa was hit hardest by AMR. I think I knew that or expected it, but it directly causes 24 deaths per 100,000 of the population. And that's almost double the 13 deaths per 100,000 population in high-income countries. Just think about that. They get more infections and more of them are drug resistant, treatment resistant. Globally, the data also demonstrates data disparities and the lack of infrastructure and capacity for surveillance that we need to detect and respond to pandemics. But the data also reflects national and local health determinants. And a US example, for instance, is that the largest determinant of death in severe sepsis cases is socioeconomic status, with Black patients twice as likely to die as white patients. It's horrible. So this new data has given AMR visibility and, I believe, a voice. But it's what are we going to do with it to make sure that future generations don't have to pay? So we've got to think up what we're going to do, not just me, but all of you. Across the international community, I think we've raised awareness now. We're resolved not to allow the crippling inequalities of COVID-19 define this future too. Multilateral actors are raising their ambitions on global health security with universal, equitable and affordable access at the heart, and that pulls in AMR. Here in the UK, we used our G7 presidency to move beyond words, and as Greta Thunberg would say, blah, 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 and we started to move into actions and practical guides for countries to implement. Blooming hard work, I can tell you. And I've got a wonderful team working on it. For the first time ever, we got the G7 finance ministers to recognize AMR as an issue to lead on by exploring how they can strengthen development of new antibiotics through new incentive mechanisms. And last year, I joined the G7 Health Ministers Summit. It was actually in Oxford. And I set them a challenge to balance innovation, access, and stewardship, looking after the antibiotics we've already got. And I'm really proud that they agreed. It was interesting that the officials would like them to have not agreed to too much. And I went and challenged them and said, you know, are you wet? You've got to do this. And they did commit to strengthening antibiotic supply chain resilience and develop sustainable, clean and green solutions for manufacturing of antibiotics. After all, I believe that AMR is surmountable if we have leadership and we have global solidarity. And I'm also proud to be on and work with the Global Leaders Group on AMR, which is positioning AMR at the top of the global political agenda. It's a UN group bringing together heads of state, ministers, scientists. I think I count as one of those, private sector, civil service representatives. And we're demonstrating why and how AMR demands investment in systemic solutions, such as WASH, that's water, sanitation, hygiene, immunization, infection prevention and control, for instance. And you know all of this, even if you're not a specialist, because of COVID, you know how important all these things are. Well, they matter to AMR too. Meanwhile, nations have started to consider and negotiate a new international treaty for pandemic preparedness and response. Any provisions for strengthening national, regional, and global capacities and resilience, data sharing, surveillance are all directly relevant to AMR. So we have to make sure that AMR is embedded in this process, and our civil servants and ministers are working on that. I really hope that we can get for AMR to a kind of COP-style process. But AMR doesn't start and stop in UN debating chambers, so it's fascinating there. It matters in the real world, in surgeries, in farms, in laboratories, in schools, and actually on social media too. We can look to consumers to pressure supermarkets and fast food chains to supply protein that hasn't been pumped with antibiotics. I never thought I'd speak well of McDonald's, but they announced at one point a policy to eliminate the use of highest priority, critically important antibiotics, defined by the WHO, in their chickens by 2027. Someone the other day said they'd backed off, so I'm going to have to check that out. We need to remain on track. We've got to accelerate, actually. And I've even been sending my students from Trinity College here in Cambridge to AGMs of Yum and Wendy's to pressurize their shareholders to follow suit and take AMR seriously. Activist investing. If you can do it for climate change, you can do it for AMR. And this is real leadership from youth. And I hope in Oxford you'll join us on this. Why don't you get your college endowments and your university endowment thinking about it? At the local, national, and global level, we've just got to push the boundaries. We've all got to do it. The innovative collaboration you've got between Oxford University and INEOS to set up a new institute for AMR for new drugs, especially in animals, is a great example of solutions-driven partnership and leadership. And there is innovation all across the world. In response to COVID-19, I actually took a lead role to try and pull innovation, and I launched something we called the Trinity Challenge. I raised over £7.5 million, and with a new coalition of diverse partners, we committed to using data and analytics to generate and recognize best thinking to a world better protected from health emergencies. So we put up this global challenge about protecting people from health emergencies. We got 342 applications for funding, well, for the prize from over 60 countries. The winner was wonderful, PODD from Thailand, where they have a mobile app that acts as a surveillance system for their farmers, who in return for them uploading photos of sick or dead animals, they get veterinary care that prevents deadly and costly disease outbreaks, but it then allows them to marry the animal data up with the human data, and they can use it for drug-resistant infections. So there's a nice example of the things that you can make happen if you raise the money and challenge people and support them. And I am clear that if AMR is to have a voice as a global challenge, then everyone's got to have a voice in it. And I think your generation are key and have to play a big role. The achievements of the past year for COVID-19 vaccines, including particularly from Oxford and Cambridge, of course, because AstraZeneca is here, are truly inspiring and unparalleled. And actually, I was one of the people who made sure that they had funding for the MERS vaccine, which was the basis for their COVID one. And I hope that these movements forward bode well for further innovation for the AMR pandemic. I'm told that mRNA can be used to help different vaccines, which will reduce infections, bacterial infections. But as I finish, I also want to express my true hope that more young people, including women, particularly women, will be inspired to take a career path in science, diplomacy, and policy making too. Bring your voices to the table. They matter. Thank you.
Dame Sally, thank you so much for that. Well, you started your career in medicine and you've since worked in policy and education. You've worn, as you said, plenty of different hats. What would you say to students listening today about finding the right career for them and making those career transitions?
Well, I think you want to be open. When I look back, at the time, I thought every job was the best job in the world to do. So I was very lucky. I enjoyed the journey, but was open and took opportunities when they were there, whether they were offered or not. I often describe to women that I learned how to hold my nose and jump, not quite knowing whether the water was going to be hot or cold. I'd assessed it was probably deep enough. And I'd take the opportunities. But the young people who come to me, and they used to come and say, I want to be CMO, how can I have your job? I'd say, well, you know, it only comes up once every decade, and you might be in the wrong place or someone might be better. why not enjoy the journey and see whether it takes you to different places? And if you're in the right place at the right time, then good luck, because it's the best job in the civil service.
And you said that using evidence became your unique selling point in the civil service. Some of our listeners might find that quite strange. Could you give us a bit more detail about why that was such an extraordinary thing for you to do?
Well, because while some civil servants are very well versed in subjects, because they've picked it up, they didn't, it was a more general knowledge normally, rather than, well, this is what the literature says and there's a systematic review and everything. And I was always very clear what the literature said, and where we didn't have an answer. And then I would say, and so your options are, and this is the one I would take. So I expressed my preferences, prejudices, but I discovered that many people started with the preference and prejudice and then kind of used the evidence to underpin it. So an example of my present life is someone came to see me today and said, the university's put out this new policy in draft, and it says that the evidence is X. And I've gone back to the papers they've been reading, and actually the paper, or they quote, the papers don't say that at all. What do I do? And I said, you write to the university, giving me a copy so I can plow in and say, I've read these papers. That's not what they actually say, so stop claiming it. And so I played that sort of role. But I also played a role of being open about what I didn't know. And I modeled that, because a lot of civil servants found it very difficult to tell ministers they didn't know. And I would say, well, I don't know, but I know the people who will. I'll go and find out. Or we don't know, and this is our best kind of bet at this moment.
And you've described your early days in medicine as brutalizing. Thinking of the burnout issue among medical staff today, do you think that the way that health workers work needs to change?
Of course it does. This has been an emergency, and they will have had some of the brutalizing, which kind of went away. One of my daughters is a doctor, a young doctor, and her stories through the being on the front line in a hospital in her first 2 years of medicine, of looking after patients who died where she or a nurse would be the only person there, not their family, and then she'd have to ring up the family, either your relative is dying or your relative's dead, and the pain of that. I think that's as brutalizing as I experienced, and probably more so. And we'd found ways of doing all of this much better. So first of all, we need to support those who've been through it. And I think burnout is a problem for some of them. I don't think many of them will be burnt out forever, but we need to find ways to let them do other things and find other interests, take some exercise, take some time out. And I think it's very difficult for politicians to see the NHS as a group of people who are doing their best rather than a machine. And they talk about levers, and if we pull that lever, will we get more, less patients on the waiting list and more out of the system? We need to remember it is people, and we've got to support them.
And have you seen much change over the course of your career in how the Global South is supported in health challenges? So thinking from the era of HIV and AIDS to the modern COVID vaccine discrepancies, what do you think's changed?
Well, I think we had a high, as it were. When the Labour government set up the Department for International Development, DFID, we really had a high alongside the Americans, where we would support not just putting in infrastructure with the name of Britain on it, UK aid, but support development. A lot of people talk about the Ethiopian, before the present civil war, health system and how good it is. We put in the money through the Ministry of Health. We put in the thinkers, we put in the program managers. Ethiopia rightly takes the credit, and that's wonderful. But we were doing really well. We supported Rwanda, South Africa, many countries. I think it's gone backwards, in part because we've reduced the amount of aid by a significant amount, and I find that upsetting. But also we saw vaccine nationalism, and that isn't the best way of handling this. The reason we cannot say that COVID has gone away is in part because so much of the low-income world is not vaccinated, and so they may develop new variants that can sweep into the global north. Meanwhile, it's been going around so much, it's got into the animal community that, for instance, the hamsters in Hong Kong, they've just killed, sacrificed, they call it 2,000. It's in the deer in the States, and they can mutate. Had we developed the vaccines as we have and got them out to the low-income countries, maybe that would not have happened. And then the threats, long-term threats, might have been different.
And what do you see as the future of COVID-19? Do you think we are nearing the endemic stage, or do you think there are more surprises for us ahead?
Anyone who knows anything knows you can't really predict this. We are clearly coming out of a bad period, and I'm hopeful that through till the autumn we may be all right. But we've been going in waves. There will be more waves of variants. The question is, are they going to be as mild for vaccinated people as Omicron, or are we going to get a new Delta or something like that? And only time will tell. And these animal reservoirs are terribly worrying, and the unvaccinated as well.
And what can we do to prepare for that future?
Well, I think the vaccine manufacturer is going well, and we are beginning to get vaccines to low-income countries, thankfully. We need to really put our minds to that. I think we're getting better treatments all the time, and those will come online. And people know now that when we've got a variant racing through the population, that there are sensible things to do. Social distancing, wearing face masks, perhaps not traveling. So I think we will all kind of keep lapsing into that behavior if we see risk.
And you've worked extensively with the World Health Organization. What are your reflections on the role of the WHO during COVID-19 pandemic?
Well, clearly they were too late in calling a pandemic, and they've found two problems. One, how do you handle this within a political context? And it is too politicized. And two, how do you support low-income countries when you haven't got any money? Because they haven't got much money. So it becomes a really difficult balance. So I think they haven't done badly, but you'd hardly give them top marks. But then could anyone have done it? I think that the Director General hasn't been given a good hand to play.
And let's return to AMR. You've spoken about some of the systemic changes that we need to see, but could you speak more on what the average Oxford student or member watching today can do to help end this problem?
Absolutely. Well, let's start with ourselves. Protect yourselves from infections, hand washing, and vaccines, because you might think that a flu vaccine, if you're offered it, is, well, it's a virus, so it won't respond to antibiotics and it doesn't matter. But actually, not passing flu to people who are vulnerable, who when they get flu get more chest infections than they would otherwise get, does protect from infection, and therefore the use of antibiotics and resistance. So prevention, remembering that antibiotics don't work for viruses. So if you feel rotten, you go off to the doc and he says you don't need an antibiotic, then please listen and don't take one and don't push. And helping others understand the issue. I'd love to see you, doing some activist work with companies about, are they in the food chain misusing antibiotics? That would be wonderful. So I think there's a variety of things you can do, and actually clamoring for more money for development of new antibiotics is going to be one of the very important ones, and fairness to the world. I told you about the deaths from AMR. What I didn't tell you was deaths from infection untreated are even higher.
And you spoke about ethical investing or activist investing. You've been the Master of Trinity College, Cambridge since 2019, and you also serve on the International Advisory Board of the Blavatnik School of Government here at Oxford. As a leader in higher education, what do you think about educational divestment from sinful industries, and has that changed your opinion on how we invest?
Well, my college has announced that we are moving to. We've disinvested based on carbon and things already within 6 months of me arriving, not because of me, the fellows wanted it. I've just discovered last term that we still had some residual investments in tobacco. They've gone. Now, council agreed. So clearly I believe that investment policy can impact, and I think we have to look at how we use that sensibly. Indeed, I work with a group we launched at a Davos meeting a couple of years ago before COVID. So it must have been January 2019, Investor Action on AMR, and we bring together a charity, FAIR, an NGO called Access to Medicines, and our government to work with a number of companies. Aviva's one that's very good, on where long-term investing goes and how you don't want to invest in companies that misuse antibiotics. And so investor action is really good. So ask your parents about their pension funds. Are they being invested safely and fairly?
And many of our members will have been told before, don't push your doctor for antibiotics if you don't need it. Superbugs are a dangerous thing. Why do you think you had to work so hard to push the idea that AMR is the next pressing global health challenge?
Well, AMR doesn't really, as a term, kind of turn anyone on, does it? It doesn't. Superbugs is rather better, but AMR is much broader, and it's so diffuse. It's not like TB or malaria, one bug and you can produce someone. It's messy. So it's all of that. And because it's messy and diffuse, we haven't really managed to get the patient advocates that advocate for heart disease and cancer or sepsis. Indeed, I was told by someone who was putting up sepsis that I should get out of the way. They had to sort sepsis. And I did say, you won't sort sepsis in the presence of AMR. I'm trying to help you. No, it was a man, you can imagine. Some bossy man telling me to get out of the way. It was very funny. Silly man. So I think we haven't done well enough yet. And I think I can understand why we haven't, but we have to do better. And I think this new data and COVID-19 give us a reset opportunity. But I don't want to change the word from AMR because I can't find a good one. And actually, we've now got the UN politicians and heads of state beginning to know, oh, AMR, yes, that's that other pandemic, slow. I'll think about it on another day, but they have heard of it.
And you've also spoken out about the dangers of overindulgence in alcohol among women, the obesity epidemic, and the prevalence of junk food in modern diets. It does seem like we're experiencing a revolution on both counts, with increasing numbers of young people avoiding alcohol or adopting sort of vegan diets. Do you think that that's a significant trend, or do you think that that's more of a trend amongst a small elite?
Well, I think the reduction in alcohol drinking is a long-term trend. It's been going for a few years now, and congratulations, young people, that drinking is more moderate. We've even seen it in, I can say this in the Oxford Union, in our own college, that less wine is drunk at feasts than it used to be. it really is true. But it is difficult for the other things, because we all know that the easy option is, and the cheap option is, unhealthy food. Veganism is probably a middle class trend, but vegetarianism is really catching on around the place, and I'm delighted. I'd like people to eat many more vegetables, and it is the young who'll lead it. So how do we make it that you can eat well on vegetables and they're easily accessible and have a variety? I was discussing over lunch how I'd love to see a system where we taxed highly processed and sugary and, well, calorie dense food, and use the money we got to subsidize vegetables and fruit.
And I want to make sure that we leave time for some audience questions, so we'll move to those shortly. But before we do, you're a trailblazer in medicine, politics, higher education, and you've spoken a lot about your experience as a woman in those fields. How do you reflect on your career now, and what message do you have for the young women in the audience who might be inspired by you?
Well, I think I've had lots of fun. And along the way, by working hard to my values, I've not only had fun, but I have made a difference. And that was what I wanted to do. So if I reflect on it, yeah, I'm not doing badly. The trouble is I haven't finished. There's so much more to do.
Well, let's move on to audience questions. Our first one is from Nessa, who says they're curious about the differences between new and more traditional antimicrobial discovery versus more advanced new modalities, such as targeting multiple mechanisms simultaneously. Will these both be required in future, or do we need to shake up our whole approach to antimicrobials?
Oh, thanks. Well, we know that if you have an antimicrobial that only goes for killing or stopping growth in one way, that resistance occurs quite quickly. So if we can find antimicrobials that work in more than one way, or even make mixtures of drugs that work in different ways, we're less likely to see resistance. So I'm pretty keen on that. But I think some of the old methods may come back. There's, I know of 2 groups researching phage technology, and they may have a role. And people are beginning to look at the immune response. Can you do something different by modulating how the body responds to infection? So I think we have to explore all these different ways, because for the very ill, we'll need all sorts of esoteric things, but can we find ways that, you know, are much cheaper and easier and won't give you resistance like the antibiotics we've got?
And Aaron asks, you touched upon the disinterest of pharmaceutical companies to develop therapies which primarily currently affect low-income countries and cause acute illnesses. For example, antibiotics are far less profitable than MABs used to treat certain chronic conditions. How do you propose that we should remodel the industry to encourage the development of novel antibiotics? And on a similar vein, Emily asks, what are your thoughts on the Netflix subscription model for new drugs?
Right, so well done, Emily. You know about what we've been doing. It was difficult to get it going, but essentially what we've done, and through G7, we shared, the finance ministers, we shared with other countries to try and get them to sign up to do their versions of it, is we've said that antibiotics have a broader value than to just an individual patient. And when we get a new treatment in the NHS, it goes through a health technology assessment, and it is costed how much it costs to save a life year, a DALY, and that's runs at the moment, I believe, at about 30,000. Well, at that rate, antibiotics, well, because they're mainly generic, we don't seem to pay enough to make it worthwhile for drug companies to do the research development and bring them through. Remembering that if they provide a new drug, what I really wanted to do as CMO was say, thank you, I'll put that in the drug cabinet until the odd patient who can't be cured in another way can use it. So they're not going to make their money on piling it high and selling it cheap. So what we've done through the Netflix subscription process is try to do an evaluation which looks not just at the individual gain, but the gain of the insurance value of having that drug on the shelf, the gain of not infecting other people in the ward, not infecting other people in the community, and what that means, and the gain that that person has of going back into life, with the view to negotiating a price with the drug company where we pay a subscription year after year, but it doesn't matter how much of the drug is used. So it can be stewarded and used sensibly because they are getting the right amount of money. And it's proved very interesting, and I think we should do more. The Americans are really excited about it, and they have on Capitol Hill a Pasteur Act, which is bipartisan, and we're hopeful will go through, which would put a big sum of money in for one of these, they're called pull incentives, but subscription-based programs. And if they do that, that'll be game-changing for the world. But it's looking in that sort of way, how can we do innovative financing, that's fair, that allows the companies to reckon that they may not make a lot of profit, but it's worth doing. They'll recoup their costs and gives us what we need without wasting money.
And how do we go about proposing that to companies and governments presenting that idea?
Well, that was why we used the G7 finance ministers, and I go off and visit countries and go into their finance ministries with our ambassador or someone from the mission to explain what we're concerned about and why and what they might consider. So it's very much a big diplomacy trying to get there, and it involves the academics doing interesting modeling. It involves the drug companies helping. To be fair, the drug companies put together a fund of $1 billion, the AMR Action Fund, to try and keep the system working while we see if we can find a way to unlock it.
And Victor thanks you for your work in the Lancet AMR paper and asks, why would you say that Big Pharma has largely subsided away from investing in research and the production of novel antibiotics? And are there any specific unexplored avenues that you propose resistant microbes or biofilms can be eliminated?
Ooh, I wish I knew the answer to the last bit. What are the specifics? I'm a hematologist and a public health physician. I know the scientists will find things. I think we just have to understand that for pharmaceutical companies, the profits from monoclonal antibodies, from novel cancer treatments and everything are massive. And the Western world, the global North, has set up these companies to make profits. And so some of them, and I've accused AstraZeneca in public, the chief exec, are free riders. So I said to him, why did you sell off your antibiotic development stuff? There was a very nice one, but we've managed to find a way to help keep it going while it develops. And he says, well, other people will do it. I'm after the profit. So there's a lot of work to be done, but we can get there.
And Alison asks, activism is a dirty word these days. Were you applying today? Would you still get the job?
I don't think I knew when I became CMO that I was an activist. It was only when I looked back with my husband at my whole career that I realized I'd been an activist as a student, anti-apartheid, as a matter of fact. And then I was an activist about sickle, raising the awareness and getting good services and research. An activist to get the NIHR to happen. And then, of course, as CMO. So I don't think I knew at the time, but I sure am a campaigner.
And Jana asks, you've worn many hats in your career, focused on many pressing issues. What would you say is closest to your heart, and what have you enjoyed the most? And are the two different?
I think all those campaigns I have cared dramatically about, because they will change people's lives for the better. So clearly at the moment, I really care, and I have done since 2011, care about AMR. But I've enjoyed all my career. I'm really lucky. I've worked with amazing people, done amazing things, and I'm very lucky I've been allowed to do the things I've done.
And B asks, you haven't commented on the government's efforts to constrain COVID. Is there a reason for that?
Yes, I think my success is great. I mentored him, but I still feel bruised when my predecessor went out and talked about my performance. Particularly bruised because I felt I couldn't respond, and on one occasion he was scientifically wrong, and on the other he was security-wise wrong. So I made an offer, which was before COVID. As I left, I said to Chris Whitty, you will not see me comment on your performance at all, but I will send you the odd text. But most of the texts are, well done, or gosh, that was difficult, glad it was you. So there you are.
Well, Dame Sally, it's been an absolute pleasure hosting you this evening. I'd like to finish with a question that we ask all of our speakers, which is, if you could give our audience one thing to think about this week, what would that be?
Stay true to your values, but you can't do anything without working hard.
Dame Sally, thank you so much. And thank you, members, for joining us.
Thank you. Have a good evening.